and implemented a national platform called My Research Results, enabling secondary genomic research results to be communicated to research participants. So Mary-Anne, we're looking forward to hear your talk on cutting-edge approach for returning genomic results.
Thank you. And thanks for the organisers for organising this session and asking me to giving me the opportunity to speak. I was just listening with great interest to Heidi's talk, and there are things I agree with Heidi on, and there are things, I suppose, that I think differently about. I think very much it's context dependent, and I really agree that one size doesn't fit all. But I think the horse has bolted, actually, and I think particularly in Australia we've been returning research results since about 2010, and particularly in Australia, for us, the horse has really bolted. So what I'd like to talk to you about today is a platform, a national platform that we've set up to support researchers to return genomic information to research participants. Most of these research participants are not what I'd call socialised with genomics. Many of them are in large clinical trials where genomics is actually a sub-study of the main trial. So I'll give you an example of a cohort we're working with at the moment, which is the Australian Parkinson's Mission. It's for people with Parkinson's disease. It's a drug repurposing trial. There's 4 arms to the trial, and they're doing whole genome sequencing in a subset of participants, and we're returning the results to those people. Before I start, I'd like to acknowledge the Gadigal peoples of the Eora Nation, the traditional custodians of the lands on which the Garvan Institute is located in Sydney in Australia. And I have no disclosures regarding commercial matters. I think the first 2 speakers have really covered the issue that the increased use of genomic sequencing means that we are going to have secondary findings, and as Heidi pointed out, you can actually actively search for these or they can incidentally arise. And depending on the study, so it's good to know how many people will actually carry one of these findings. Depending on the study and depending on the cohort, it's about 1% to 6% of people who will carry a secondary finding. And our definition of a secondary finding is a medically actionable variant that's unrelated to the initial testing or the primary condition that the person presented with. And it's one thing, as Heidi was talking, that I was thinking about. We really need to agree on some terminology. Because it's very confusing for researchers and research participants with regards to what it is that we're actually talking about. So as we're witnessing here today and through this conference and for the last many years, there's ongoing debate about the types to be returned and the methods of return. I would argue that the horse has bolted and we actually need to concentrate more on strategies to manage returning the results. I'm going to particularly talk about the program we've set up, which is mainly adults, but we are now starting to return for paediatric studies. I think it's really important to think about the context, as Heidi was talking about. What is the actual rationale for the research? Is it genomics-led, or is it genomics that's a sub-study of the actual trial or research? Is it a population-based study? Are there controls involved in the study? Why? Why would you bother doing this? As we can see, there are people walking around out there, some of us in this audience, who are not aware that we actually carry a high-risk variant. And by informing people, they can proactively manage their increased risk using evidence-based risk management strategies, with the ultimate aim of reducing morbidity and mortality from disease. I understand that's a very public health way of thinking about it, but in some ways, if you think about genomic testing, that's actually sometimes what we're trying to achieve. Heidi mentioned the guidelines. First of all came the NIH guidelines, and we now have the E08.2, which Heidi talked about as well. And I'll just talk to you a little bit about the Australian guidelines. We also have the recently American College of Medical Genetics, who annually have a working group who sits and goes through the genes that they think should be returned, or that they not think, they deem are able to be returned, and we're now up to version 3.1. These guidelines are actually for clinical laboratories, not research laboratories, but many researchers actually use these guidelines as they're evidence-based. In Australia, the National Health and Medical Research Council has developed guidelines, and they state that researchers must develop an ethically defensible plan when putting their research protocol together. And they have the choice to not give back secondary findings, or the choice to disclose them. But that information must have health implications to the participant and their relatives. They must be asked if they wish to know that information, and they can decline. And they must be provided with clinical advice and counselling at a minimum if the information is disclosed. I think the thing about guidelines is that they're really good in talking about the broad brush concepts, but they don't actually tell researchers or help them in how they go about it. And I think that's where the gaps are at the moment. And if we look at this document, what researchers are faced with, who often know nothing about genomics, they know a lot about other things, cell biology and whatever, and they are faced with this, and they just throw their hands up and think, oh my God, what am I doing? How do I know which part of this decision tree to go down? So I think we're asking a lot of researchers who aren't familiar with genomics to think about returning research results. We've already heard that research participants wish to know their results regardless of hypothetical, actual, biobank, patient. And there's a couple of studies in the US that are showing that research participants actually see it as a prerequisite now for taking part in research. So there's that notion of reciprocity, that I'll take part in your research if you give me something back, and Heidi spoke about that. Broadly, what we understand at the moment about the psychological impact is that there's no significant differences in anxiety, depression or psychological burden, whether it be positive, pre, post. And what we're seeing with the data is that these people are mimicking the psychological response, or having the same psychological response as people who come to our genetics clinics. They have a period where they are shocked. And that happens when you see, as a counsellor, you sit across the room and you can see, no matter how much people have thought about it, they're still shocked when they get the news. And I often say, you can't know what it's like till you get there. But what the data shows with the research participants as well is that 4 to 6 weeks post results, they're starting to value the information. They say that their stress has settled down, and they're highly satisfied with receiving the results. And they've even talked about feelings of empowerment. It's not to say that there aren't people who will have some depression and anxiety, but they're often people who have had depression and anxiety before. So your pre-test state, often in predictive testing, is your post-test state. They're fairly similar. What do we actually know about what people do when offered research findings? So as Heidi talked about, we know that there's broad range, somewhere between 20 and 98%, but the majority of people take it up. But the uptake is dependent on the way that they are notified and managed, and that's really informed the program that we've set up. The reasons that people take up the information is that they consider that there's actions that they can take based on their result, not only for themselves but also their family member. The reasons they decline is they already know that they've got a variant, or they don't want to know, or they're concerned about insurance implications. When we think about why we give people back this information, part of it is so that they can talk to their family about it, and their family can then have the option of cascade testing for themselves. And what we know about family communication when people are given variant information in research settings is that they do talk to their families about it. And again, the same reasons that they cite are what we see in families who go to clinics who have strong family histories or personal histories. They have a concern for their family members. They feel a sense of genetic responsibility to share that information with their family members because they want them to have access to that information. Of note, there's a couple of studies that have shown that if the results are actually given by a genetic counsellor, it's much more likely that the family will share, that the research participant will share their results with their family as compared to other health providers. And that's quite significant, 52% compared to 11%. And again, we know that researchers also support the return of findings, but they face significant challenges. They have a lack of training in communication. They don't have the infrastructure to store the information, and they have difficulties with participant contact. They're not trained to do this. So now I just want to take you to Australia, a long, long way away from here, I can tell you. We have a parallel health system, which is that we have a public health system and we have a very good private health system as well. We have a small population for a very large land mass. We have about 25.5 million people. Nearly 4% of our population are First Nations Australians, and a significant number of people are born overseas. You can see the countries there, England, India, China, New Zealand and the Philippines, and that's just due to geographical location. If you look, most of the population of Australia is around the coastal areas, and that's because the country is too large and too dry to live in the centre. It's not sustainable to live there. And that impacts the way our health services are delivered. So we have a lot of health services around where the populations are, but we need to be novel, particularly in the way we think about delivering health services to areas that are remote. So just to take you back, as I said, in 2010 we started giving back research results, and the first cohort that we gave them back to was called the Australian Ovarian Cancer Study, which was a population-based study of women who had ovarian cancer in Australia. And we did some follow-up interviews with women who were notified that they had a BRCA1 or 2 mutation. And what we found that there are a number of factors that actually precluded these women having access to genetic counselling and going to a familial cancer centre. So in Australia, what happens with the results is that the result is a research result. It's not clinically validated. And we actually then have to see, these people have to be seen in a clinic and have a second independent sample taken, and the result has to be validated in a NATA accredited laboratory. So what the research findings showed from this study was that the process of notification by just sending people a letter was not enough. They didn't understand it. The letter was too vague, and they had unmet information and support needs. They also encountered significant barriers when they went to try and make an appointment in a clinical genetic service, and they just gave up. It was too hard. What was the most interesting thing out of this is that these interviews were conducted by research genetic counsellors, and once the interviews were finished, the genetic counsellor actually then said to the participant, look, I'm not the researcher anymore, I'm actually going to tell you how you can get to this service. And so the interview acted as an intervention. So the genetic counsellor was then, some might think this unethical, but we didn't. Some people, we addressed their unmet information and support needs. We advocated for them to get appointments in familial cancer centres, and the research interview actually acted as an intervention, which was rather ironic at the time. Then Dr. Laura Forrest, who's here, and I went back and looked at all the literature, and again, looked at the literature in the US, in Canada, and the letter only was not optimal. And people do need more information and support to facilitate their decision-making about whether or not they wish to take up these results. And of course, being a genetic counsellor, and Laura's a genetic counsellor too, we propose that these results should be given back by genetic counsellors. Why? Because Genetic counsellors are health professionals who've got experience and skills in communicating genetic information to facilitate decision making. And they know how to talk about family communication, and they can also advocate for people with regards to getting appointments. So now onto the platform that we've developed. It's called My Research Results, and it's an evidence-based genetic counsellor-led national platform throughout Australia, and we facilitate the return of primary and secondary research findings. So what we do is we connect researchers with their research participants, and we connect the research participants with the genetic services. So we're the method of returning research results in the middle that Heidi was talking about. We are embedded in a research institute, we're not embedded in a hospital, and we act as a broker, basically, between the researcher, the research participant and the clinical genetic service. We've published a protocol paper if anyone's interested in reading more about it. And the platform has two functions. It has a service function and it also has a research function. So as I said, we work with researchers. We actually help them write their ethically defensible plans. We help them write their consent forms. We work with research participants, and I'll explain a little bit more about that. And we have a research function as well. So we're actually looking at the psychosocial implications of receiving this information on adaptation, clinical and personal utility, health economics, and we're looking at what the Australian research preferences are because there's no data around that. When we set this up, we had to think about the service function development, and our aim was to support researchers to develop and implement an ethically defensible plan for managing research results, which was consistent with our national research guidelines. So we established a steering committee, which we had consumer representation. Then we had to think about, because we're located in a research institute, about security of the information. So we've had to look at the privacy laws and have had to keep our information more secure than some of the other research information. The other thing we have to think about is scalability. We have we have genetic counsellors who work, people can ring them at any time. We also have an online booking system which people book themselves in for, and it's really well used. We have a portal under development, and we're constantly looking at information storage. We then had to establish relationships with the clinical genetic services to tell them that we'd be ringing them up and asking them to see these people and prioritise them on their wait list. We then developed research and participant resources. We developed a website. To do that, we conducted focus groups with research participants. And we also developed a secondary analysis pipeline for our internal cohorts. So we actually provide this service to both our own research cohorts within the institute that we work, but we also provide it to other researchers throughout Australia. Our guiding principles are that the return of results process is collaborative, client-centred, supports research participants and their family to make informed choices about receiving or actually not receiving their results. And I think what this process does, it gives people an opportunity to opt out if they don't actually want to receive the results. We only return class 4 and 5 variants. We don't return anything else. We can't return VUSs. There's just not enough information known about it, and I think it creates more confusion. So we return the results from the ACMG version 3.1, and that's what we use for our secondary pipeline. We have clinically trained variant curators, and that reduces the risk of a false positive result. And we also have established a genomics multidisciplinary team meeting where we look at the variants that we're not so sure about. And then, as I said, we actually refer people to clinical genetic services. We make sure they get there. We follow them up to make sure they get there where they have ongoing clinical management. And that includes verification of the research result, risk management, family communication and cascade testing. Initially, we only returned secondary findings, as I said, to internal cohorts and external cohorts, mainly population-based research, but we returned it to adults and next of kin. So if the research participant has deceased, we do contact their next of kin. And most of those were for diseases that had a common complex background, like, as I said, Parkinson's disease, or there's eye disease cohorts that we're working with. But due to the unmet need, we're now starting to return primary results, and that is, there's a large population genetic screening program going on in Australia at the moment, and we're returning the primary results for that. And we've been contacted by some researchers who are doing a cerebral palsy study in the paediatric setting, and they'd like us to return the results for those. So there's a real unmet need in this space. How do we do it? We have what we call a two-step notification process. People are actually sent a letter in the post, and that letter says, you may or not remember, but some time ago you took part in this study. At the time you consented to the study, you said you wished to be made aware if anything was found in the study that could impact you and or your family. We may have found something, and we'd like you to ring this number. And they have a toll-free number that they can ring, or they can book themselves in for an appointment with a genetic counsellor, and then it says, and if you don't ring us, we'll ring you in 2 weeks just to make sure you got the letter. So people ring, and we can either give them the result on the phone, and nearly all the people who ring want their results straight away. Or they can be referred and have their result disclosed when they go to the clinical service, but most people don't want to do that. Or they can decline, or they can defer their result if they like. So it's very client-centred as to what people will do. We then refer them to the clinical genetics service. We write the referral letter. We then write to the participant summarising what we've talked to them about, like happens in clinical genetics practice, and we send a copy of that letter to their general practitioner. When the notification process has finished for that cohort, we then write back to the researcher and let them know what happened. So we give aggregate data to the researcher so we can sort of draw the line under that. We don't have any plans for reanalysis at this stage. So to date, we've returned 160 results. The average age range of people, they're 52, with a range from 19 to 93. That's a broad range. We're working with a very, one of the cohorts is a very older cohort. You can see the data there, that a lot of the results have been returned in Victoria, but that's basically because there's a big study going on there. And we have a proportion of female, 57%, but also a significant proportion of men who are receiving results as well. We have returned results to 12% to the next of kin and to the participant themselves, 88%. And these are the cohorts that we're currently working with. This is the large population-based DNA screening program that's going on at the moment. These are the genes that we've actually returned results for. You can see that we have the cancer phenotypes. BRCA2 is very well represented there. We have Lynch syndrome, Lee-Fraumeni, and then we have the cardiovascular phenotypes. One of the interesting things is familial hypercholesterolemia, which is often underdiagnosed in populations. We've actually given back a lot of results for that. So with the 160, just to tell you what's happened, 155 have been contacted. Only one person declined their result because they didn't think it was relevant to them. They didn't have any children. 154 have received their results, and of those, 123 have accepted their referral. 24 already knew they had a variant. In that case, what we do is we contact the clinical service that they were seen at to make sure it's the same variant and not a different one. And then 7 have actually declined referral. So if you think about decision making and some of the ethical concerns about people having the choice to make a decision, you could argue that this process actually gives people time to reflect and actually consider whether they really want these results or not. Just looking at our data on regards to what happens, about 30% of people call us. Interestingly enough, most people seem to book in on our online booking system to talk to a genetic counsellor. And then there's a proportion where we actually have to ring them. When we ring them, we just ring to make sure they got the letter, and if they've got any questions, we're not trying to coerce them into having their results. The average time to contact is 10 days, with a range from 30 seconds after they get the letter right through to 3 months. These are our cohorts, and they're very different cohorts. Asprey is a cohort of older people. They're called the elderly. They're people who are in their 80s and 90s, and that was a trial looking at aspirin to reduce bowel cancer and heart disease, and they did some whole genome sequencing. BioHearts is a big cardiac cohort that we're working with. As I said before, there's a cohort of children with cerebral palsy. We've got an inherited renal cancer cohort, and this is an interesting cohort called Intrepid, which is nearly 200,000 people who consented to research some over 20 years ago. And we will be contacting them with results, and we anticipate there'll be a lot of next of kin. Our research, just flipping now from the service to the research, we've decided to focus our qualitative research on some of the gaps in the literature. So women are very well represented in regards to returning research results because of BRCA1 and 2, but we want to hear from male research participants, and we also want to hear from next of kin about what the impact is. We also want to interview people who have received their findings 10 or more years after their initial study recruitment, and we also want to talk to people who've received a finding that they've got a moderately increased risk. From a quantitative perspective, we're going to do a service evaluation, and we're going to look at some of the psychological and behavioural impacts. What else we're looking at, which requires more evidence, is what are the health economic benefits of actually returning this information, and what are the long-term clinical outcomes for people? Does returning this information make a difference to people and their families in the long term? I just want to quickly finish off with what the implications are for genetic counselling. I couldn't do that without being a good genetic counsellor. How I think about this is that the models of service delivery for most genetics clinics have been developed for personal and family history reasons. Research participants actually present with results, and the term genome first care has been coined. And that requires thinking differently about models of service for these people, and I think, as Heidi talked about, there's no one size that fits all. For the profession of genetic counselling, I think it has implications with regards to education and training, and also for the workforce. So in summary, what I hope I've been able to explain to you today is a program that supports researchers to give back results through a genetic counselling process. And it supports the transition of genomic information from research to the clinic. It's evidence-based, from Evidence in Australia. It's a national program. It's developed based on context. It's flexible, it's adaptive, and it's provided by genetic counsellors. Just my references, and I'd very much like to acknowledge the team who actually make all of this happen. This here is some very important people, including Jodie Ingalls, who's here, who's part of our genomics MDT. And acknowledgements to our collaborators. Thank you for your time, and look forward to the discussion.